Over to you, sir.
Thank you, Ms. Krishna, for that kind introduction. And today we'll be discussing about management of persistent pulmonary hypertension. So in the next 20 to 30 minutes, I will be talking about incidence, principles of treatment, how to ventilate these babies, what are the different treatment options available to us, a word about treatment of choice, that is inhaled nitric oxide, few newer therapies, and finally long-term outcomes of these babies with a pinch of evidence. As a neonatologist and as a pediatrician, we all know that persistent pulmonary hypertension is one of the serious medical emergency which we see in our NICUs, and it is a dreaded disease with a mortality of around 10 to 20%. The incidence varies from 1 to 2%, and broadly it can be classified into two types. One is primary PPHN, and the second broad category is secondary PPHN. In primary PPHN, there is no evident lung disease which can explain the persistent pulmonary hypertension of the newborn, whereas the secondary PPHN, which constitutes around 80% of the total PHN, is often secondary to lung diseases like mucocilium aspiration, pneumonia, sepsis, lung hypoplasia, other malformations like congenital diaphragmatic hernia. It is very important to classify this disease because based on the classification, we can know the basic cause of the PPHN as well as its pathophysiology, and similarly, we can aim our treatment principles depending on the underlying cause. Now, the management involves basically the four broad principles. Some of them are the non-specific ones, and then the specific therapy. In the non-specific therapy, we first have to reverse pulmonary vasoconstriction, because we all know that, as the name itself suggests, that PPHN is persistence of pulmonary hypertension. Normally in fetal life, the lungs do have high pressures, but as soon as the baby is born, as soon as the fetus comes into this world and there is a change of physiology, these pressures fall and there is increased blood flow to the lungs, and which improves the oxygenation, and further this oxygenation causes vasodilation, and there is increased blood flow to the lungs, and subsequently increased blood flow to the left side of the heart and increased cardiac output. Now, if because of some reasons there is failure of fall in this pulmonary pressures, there is decreased blood flow to the lungs, which causes hypoxemia, decreased blood flow to the left part of the lung, decreased cardiac output, and then the complication and a vicious circle starts. So first of all, we have to reverse the pulmonary vasoconstriction. So we'll discuss about in detail in subsequent slides. And similarly, because there are increasing pressures on the right side, there is a shunt going on across the PTA from right to left. So we also have to maintain a normal or a slightly higher normal blood pressure so that we can reverse this right to left shunt to left to right, so that more blood flow goes to the lungs and there is improvement in the hypoxia. Similarly, as we discussed that in secondary PPHN, the underlying cause of the lung has to be treated. For example, if it is because of the pneumonia, we have to give antibiotics. If it is because of the mucocilium aspiration syndrome, we have to ventilate, we may have to give surfactant. And then last but not the least is specific therapy. In specific therapy, we give specific pulmonary vasodilators, and the first and foremost, the important one being inhaled nitric oxide. Now, coming to the acute management in babies with PPHN, first of all, as we discussed previously, that we have to ensure that there is a normal milieu anterior. That is, we have to ensure that there is a normal acid-base balance, because acidosis in itself is a strong pulmonary vasoconstrictor. So we have to maintain pH above 7.25. Since these babies are hypoxemic, they are agitated, so we may have to give sedation. This is in fact one of the only indications where we may have to give sedation while ventilating a babies. We have to optimize the ventilation strategy. That is, we have to open up the lungs using different modes of ventilation. And we have to treat underlying causes like sepsis. We have to maintain normal glycemia, normal calcium levels, and baby has to be comfortable. Similarly, we have to monitor the vitals, which includes pre and post ductal saturation, oxygenation index, and we have to do echo as soon as possible. First, to diagnose it as a case of PPHN, and second, very important, is to rule out any other underlying congenital heart disease. Now, once we do the echo and if there is evidence suggestive of PPHN, then the drug of choice remains inhaled nitric oxide, which is a selective pulmonary vasodilator. In 10 to 20% of the babies, they do not respond to nitric oxide. In those babies, we may consider other drugs like sildenafil, which is a phosphodiesterase 5 inhibitor. We'll talk about in detail in subsequent slides. And we may also try other therapies like aerosolized prostacyclins or iloprost. Systemic prostacyclins can cause severe hypotension and therefore they are avoided in sick babies. On other hands, if the babies have PPHN but they are in shock, they may require a fluid bolus depending on our echo findings. And these babies may also be started on dopamine 5 to 10 micrograms. Remember that do not give higher doses of dopamine because itself can cause severe pulmonary vasoconstriction. Now, it is very important to know that whether the baby has a normal LV function or abnormal LV function. So since in PPHN, there is always increased there is increased resistance to the right ventricle, so there are high chances of right ventricular failure. So since both the ventricles dependent on each other, so once the right ventricle fails, there is also failure of the left ventricle. So if there is evidence of left ventricle failure in the form of narrow pulse pressure, then then the drug of choice or the inotrope of choice becomes epinephrine. And whereas if it is a case of, whereas if the LV function is preserved, for example, it's a case of sepsis where we have a wide pulse pressure, then the initial inotrope or vasopressor becomes norepinephrine. And subsequently, if there is no response, the BP continues to remain low, we may have to add hydrocortisone. We'll talk about in detail in subsequent slides. So once we are doing echo and if there is a narrowing PDA, that is PDA is about to close, there is a constricting duct, we may have to keep it open with the help of prostaglandin E1 infusion. Now, the importance of keeping the duct open is because since the pulmonary pressures are high, this PDA, that is patent ductus arteriosus, acts as a pop-off valve. So the the blood moves from right to the left, and if this duct is closed, it will further increase the pressure. So it is very important in a constricting duct where the right pressures are very high to keep open it because it acts as a pop-off valve. The other drug which may be used in LV dysfunction, which will be seen in echo as mitral regurgitation, failing left ventricle, we may have to use milrinone. Milrinone is again a phosphodiesterase 3 inhibitor, and it also increases the inotropy of the heart, that is the inodilator. And in very severe hemodynamically unstable cases, even if after giving vasopressors, there is no response and OI is more than 40, one may have to consider ECMO. Now coming to the one of the basic principles which we discuss is that we have to reverse the pulmonary vasoconstriction. So for that, it is very important to maintain a thermoneutral environment. The baby should be handled minimally, because one of the characteristics features of PPHN is that they have fluctuating saturations, because as soon as you touch the baby becomes agitated and they'll end up in hypoxia. So baby should be minimally touched. They should be properly sedated. Analgesia should be given wherever required, and a proper fluid balance has to be maintained. The glucose, calcium has to be maintained. If there is anemia, it has to be corrected, because we all know that hemoglobin is the carrier of oxygen, and polycythemia similarly has to be avoided, because once there is polycythemia, there is increased viscosity of the blood and blood flow becomes sluggish. The PO2 has to be maintained between 60 to 80. There is no need to maintain PO2 more than 80 because it is not going to help. It is in fact going to cause harm. If there is underlying lung disease or underlying sepsis, we have to give appropriate antibiotics. The other thing in cases of secondary PPHN is to improve the basic lung function, which may be the underlying cause for this PPHN. For that, we have to ensure adequate oxygenation, ventilation. For diseases like meconium aspiration syndrome or pneumonia, we may consider giving surfactant if there is a picture of low volume lung. And in fact, use of surfactant has been shown to decrease the need for ECMO. HFOV and INO go hand in hand, and otherwise, if we are not using INO, there is no need to use HFO. HFOV is only required if we are giving inhaled nitric oxide. For other diseases, HFOV and other modes of ventilation, they do fairly similar. Other important strategy which we discussed is that we have to maintain these systemic pressures slightly on the higher side. The normal basic funda is that based on the gestation, we maintain MAP above the gestational age. For example, if we have a baby who is 35 weeker, we have to maintain MAP above 35. Same goes for 36 weeks. We will try to maintain MAPs above 36, but you can use specific charts also. Similarly, if the echo shows there is a low volume, then we may have to give fluid boluses. Inotropes we discussed based on the LV function. If it is a failing left heart, then we may have to use epinephrine along with the milrinone. Otherwise, we can use norepinephrine vasopressin. One of the parameters is to ensure adequate vitals are maintained. The lactates are an indirect marker of anaerobic metabolism. So our aim should be to maintain lactates less than 3 and ensure a good urine output of more than 2 ml per kg per hour. Other important thing is we should not bombard these babies with fluid, because excessive fluid can cause harm to these babies and they may land up in failure. Oxygenation, although is important, but it is very important to avoid hyperoxia, and adequate oxygen therapy has to be maintained with the PaO2 between 60 to 80. The target for preductal saturation has to be between 90 to 95, but it is equally important to avoid hyperoxia, because giving excessive oxygen leads to free radical generation, which itself can downgrade nitric oxide, can increase phosphodiesterase 5 activity, which metabolizes cyclic GMP and can worsen PPHN. So avoid saturation above 95 and PO2 above 80. Now, in ventilation, it's always important to use permissive hypercapnia. That is, try to maintain pH above 7.2 and PCO2 of 55 to 60 is tolerable. Do not give high pressures just to bring that PCO2 down. Gentilation is the new norm in modern ventilation, and high frequency ventilation has to be used along with the INO. Previously, we used to hyperventilate these babies and give alkali infusion, but there is enough evidence to show that it is harmful. In fact, use of alkali has been shown to increase sensory neural hearing loss, and it also increases the need for ECMO and oxygen at day 28 days of life. The basic aim for ventilation is to open up the lung. That is, we should have at least 8 to 9 posterior lung spaces in an X-ray, and both underinflation as well as overinflation can precipitate PPHN. So always aim for 8 to 9 posterior rib spaces. A word about surfactant. Surfactant is important in underlying lung disease like RDS, pneumonia, and meconium aspiration. The use of surfactant has been shown to decrease the need for ECMO, and usually use should be considered very early in the disease, because sooner you use, better are the outcomes. Now coming to the specific therapy for PPHN, that is use of pulmonary vasodilators. Basically, there are 4 pathways in lungs which control the vasodilatation of the pulmonary vessels. The first and foremost pathway is the nitric oxide pathway or the cyclic GMP pathway. Normally, the endothelium of our blood vessels they produce nitric oxide by nitric oxide synthase, and this nitric oxide in turns produces cyclic GMP, which is a vasodilator for pulmonary vessels. Both nitric oxide and cyclic GMP, apart from the vasodilation, they also inhibit this smooth muscle proliferation. So whenever there is disruption of this pathway because of the chronic hypoxia, for example, in IUGR babies, or because of the lung diseases, there is significant vasoconstriction, because now there is no nitric oxide and there is no production of cyclic GMP. Apart from this vasoconstriction, as we discussed, there is also smooth muscle proliferation. So they also, apart from the vasoconstriction, they also cause the change in the vessel morphology or the modulation of the vessels. Now this nitric oxide is also metabolized by phosphodiesterase 5. So this phosphodiesterase 5, if we can inhibit it, it will further increase the activity of the nitric oxide. So the phosphodiesterase 5 inhibitor available to us is sildenafil, which can be given both IV as well as in the oral form, and has been also called as the poor man's INO. So in cases where we do not have inhaled nitric oxide, we can give sildenafil, which inhibits the metabolism of nitric oxide by inhibiting phosphodiesterase 5 and increase the endogenous nitric oxide. The other important pathway for pulmonary vessels is the prostacyclin or cyclic AMP pathway. So normally prostaglandins, that is PGI1 and PGI-E2, they increase cyclic AMP, which is again a natural vasodilator of the pulmonary vessels. So these usually have been used in adults, but the systemic form in neonates can cause severe hypotension. So we generally tend to use IV form in very sick babies. We can use it in form of nebulization. Similarly, just like cyclic GMP, cyclic AMP is also metabolized by another enzyme known as phosphodiesterase 3, which is inhibited by a drug known as milrinone. So we can also give milrinone, especially if there is a left ventricular failure, which is can be detected by mitral regurgitation in echo and a small left atrium. In those babies, milrinone can be effective because it acts as an ionodilator. It decreases the pulmonary vasoconstriction, that it acts as a pulmonary vasodilator as well as increases the inotropy of the heart. The third pathway is the endothelin pathway. Basically, the endothelin receptor 1, there are two types, A and B. So A is the receptor which causes the vasoconstriction of the pulmonary vessels. So if we can inhibit these receptors with the help of a drug known as bosentan. Now the problem with the bosentan is that it is available only in the oral form. It's not available in the IV form. Although it is effective in some small studies, it is oral absorption is erratic. So it can be used in chronic cases or resistant cases to INO. So these are the fourth pathway is the oxidative stress pathway. For example, hydrogen peroxide, superoxide, oxide. And usually whenever we give inadequate oxygen, excessive oxygen provides these free radicals, which causes oxidative damage. They also decrease the endogenous nitric oxide production. They increase phosphodiesterase 3 activity, leading to catabolism of cyclic AMP. So excessive oxygen should be avoided, and we should always focus on these four pathways. The first and foremost important being nitric oxide cyclic GMP pathway. So the drug of choice remains the nitric oxide, which is in fact the only drug approved by the FDA for this condition in babies more than 34 weeks. As we discussed, the nitric oxide, it activates cyclic it activates guanylyl cyclase, which increases cyclic GMP, which is a natural vasodilator of pulmonary vessels. And majority of babies show response to this. The advantage with nitric oxide is that it has a micro selective action. As seen in the diagram to the left, whenever we give inhaled nitric oxide, the gas goes to only to the ventilated alveoli. So it improves VQ mismatch, improves oxygenation. It doesn't go to the alveoli which are not ventilated. So it improves VQ mismatch. That is, it goes only to the ventilated alveoli which have got good blood supply. The other important thing is there is hardly any systemic absorption, and whatever systemic absorption is there, it gets converted into methemoglobin. So there is no systemic vasodilation. Now, a word about ventilation. As you can see in this diagram, that whenever in conditions like meconium aspiration, RDS, and idiopathic PPHN, whenever we use HFO along with the INO, the response is maximum, except in idiopathic cases. So we all know that 80% of the cases are because of the secondary lung disease. So whenever we are using inhaled nitric oxide, it is better to use high frequency ventilation along with it. The eligibility for using nitric oxide is usually we calculate the oxygenation index. If it is above 15 to 20, we should use nitric oxide in a dose of around 20. And before using INO, it is very important to do an echocardiography and rule out congenital heart disease, especially the left side heart disease like coarctation, because use of INO can worsen this disease and can cause severe instability of the babies. Similarly, in moribund babies, for example, grade 3 IVH or massive parenchymal hemorrhage, we can avoid giving nitric oxide because these babies are already morbid, or in cases of severe syndromic or congenital malformations. For the eligibility, we remember it by a rule of 20-20-20. That is, if OI is 20, more than 20, We use nitric oxide in a dose of 20, and we see usually a response of INO by estimating that usually after starting nitric oxide, the ratio of PaO2 by FiO2 should increase by 20 or more. If it is increased by 20 or more, we say that the baby is responding to INO. For weaning, we usually, once the baby is stabilized on inhaled nitric oxide and his saturations are above 91 and his PO2 is above 60, and once the FiO2 comes down to less than 60, we start weaning. Usually, we start weaning from 20 by decreasing in decrements of 5 every 4 to 5 hours. And once we have reached to 5 ppm, then we decrease it by decrements of 1 every 2 to 4 hours. And then once we are on a minimal dose of 1 ppm, we stop it. Sometimes there may be a rebound PPHN after stopping INO. It may be because whenever we are giving inhaled nitric oxide from the outside, it down regulates the endogenous nitric oxide, and it also increases the phosphodiesterase 5 activity, which is responsible for breakdown of the guanyl CGMP. So there is enough evidence to show that inhaled nitric oxide is effective. It reduces incidence of both death as well as use of ECMO, and there is a good evidence to show that. And number needed to benefit is 5. That is, for every 5 babies you put on INO, you are going to decrease the need for ECMO. In preterm babies, INO is still in developmental stage, and it is should not be used beyond research purposes. Other therapies in babies who do not respond to INO, we may use other alternatives based on the pathways which discussed. One of the pathways is sildenafil. That is the drug which is inhibits the enzyme which downregulates the cyclic GMP. That is called sildenafil. It is used in both IV and oral form. It's very effective. Risk of hypotension is there, so always you should have a look on blood pressure whenever you are using sildenafil. And sometimes it may be used along with the INO if the babies are not responding, and even in absence of INO, it remains the drug of choice. Once in chronic PPHNs, it's a very important drug because it's available in oral forms, and babies can be discharged in the oral form in the dose of 0.5 to 2 milligrams per kg per dose, 6 to 8 hourly. And this drug should be used in liver dysfunction because it is metabolized by the liver. There is some evidence to show that it reduces the mortality and it improves the oxygenation, but it's a low quality evidence. The other important drug is a milrinone, which is especially important if there is associated LV dysfunction, mitral regurgitation, small left atrium, which are indicative of LV dysfunction. And usually, whenever there is LV dysfunction, there is pulmonary venous hypertension. And in those babies, INO may be detrimental. So, milrinone remains one of the drugs of choice in such babies. Usually, we avoid giving bolus in neonates because it causes hypotension, and usually we use it in the dose of 0.3 to 0.9 micrograms per kg per minute. Again, we should have a look on the blood pressure because it can cause hypotension. And similarly, milrinone, just like sildenafil should be used in liver dysfunction, milrinone should be avoided in using renal dysfunction. A word about prostaglandins, as we discussed, since there is the diagram to the left, whenever there is PPHN, there is right ventricular dilatation because of the increase in the afterload and right ventricular dysfunction. So this duct, which is shown in the blue here, it acts as a pop-off valve by decreasing afterload and guiding this excessive blood to the left side of the heart by right to left shunt. If it's a closing ductus or the ductus is closing, it's very important to give prostaglandins to keep open this duct because keep it open and provide a channel for excessive blood flow to move from right to left, thereby decreasing the right ventricular afterload. So in those babies, we may consider prostaglandin E1, but remember systemic therapy with prostaglandins can cause severe hypotension. And we usually, the trials, whatever are available in the form of inhalation form. The last but not the least is the bosentan, which is again we discussed is a non-specific endothelin receptor antagonist. And there are very small trials where it has been shown to be beneficial, but it is only available in the oral form. It can cause severe liver dysfunction, and the oral absorption remains erratic. The oral dose is around 1 to 2 milligrams per kg per dose BD. And the other side effects includes pulmonary hemorrhage, and it can sometimes cause severe flushing. Now, there is a recent evidence to show that steroids may be beneficial because steroids, especially hydrocortisone, has been shown to increase cyclic GMP by normalizing guanylate cyclase and phosphodiesterase 5 activity. Similar effect has been shown with IV methylprednisolone also. So in babies, before jumping to the ECMO, this may be used as a rescue therapy prior to ECMO. And there is some evidence emerging for its use and success also. The other emerging drugs, which are include L-stroline, Rho kinase inhibitors, antioxidants based on the oxidant pathway, and there are some newer phosphodiesterase 5 inhibitors like Tadalafil and Specifil, and there are other endothelin receptor antagonists which are there in the market, but still they are not in the practice and they are still in the research mode, and these includes Staxantan and other drugs. Now, these babies, once they are discharged, the story does not end there. We need to monitor these babies. We need to follow up these babies because post discharge also they have problems like reactive airway disease in around 1/4 of these babies. They can have significant GERD and poor weight gain. So they need to be assessed for their weight gain, height, head circumference. Neurodevelopment is again an issue in these babies, and they have to be assessed for neurodevelopment. Sensorineural hearing loss is another issue, so they have to be assessed for hearing function, especially in 1 to 3 years of age, and they should be comprehensive screening for all the neurodevelopment as well as the physical growth, especially preschool. Now, the take-home message is that PPHN is a very important medical emergency, but if it is secondary to some lung diseases, the prognosis is usually good, especially if you have INO. But before jumping to the INO, you should ensure that baby is euthermic, euglycemic, and should have normal milieu interior, that is normal pH. I know, as we all know after this discussion, that it is the treatment of choice and has got microselective action. In babies who are not responding to INO or where centers where INO is not available, a trial of sildenafil can be given. Follow-up is very important for these babies to assess their physical as well as mental development.